Hi everyone, welcome to today's webinar. We're just going to give a couple of minutes to let people come in. I can see people are joining now thick and fast, so we'll just wait for people to join us. Got three great speakers lined up for you today, so we're delighted that you're able to find time to join the Catalyst today. Okay, so we'll just give it another couple of minutes for those of you who are joining us. Welcome. I can see lots of colleagues just joining now online. So we'll give 2 or 3 minutes and then we'll make a start. Thanks to our speakers for joining us. We'll get going in a couple of minutes. Okay, everyone, I think I'll make a start. So welcome to today's webinar. Thanks very much for joining us. We've got a great lineup of speakers for you today. So I think many of you will perhaps have joined our webinars previously, but as you'll know, this webinar is being run by the ADR England Community Catalyst for Children at Risk of Poor Outcomes. It's one of 2 catalysts, and we're now moving into a different phase of our event series where we're focusing on evaluation. So from now through to December 2026, we'll be posting a series of really interesting and exciting events for you online via our microsite, and I'll give you the QR codes for those in a minute. We just want to draw your attention also to ADR UK's Parallel Catalyst Youth Transitions, that's also offering a series of events on evaluation. Okay, so turning to the focus of today's event, today we're focusing on the use of administrative data for evaluation of early intervention initiatives. And we have Sarah, Gareth and Tony joining us, and they're going to be talking about evaluation of Sure Start and Flying Start. So for those of you who are not familiar with these initiatives have been around for quite a while, and they were designed, going back quite a while now, the Sure Start programme to target disadvantaged children and to improve early years outcomes. So Sarah and Gareth and Tony are all going to give you an illustration of how we can use admin data to evaluate these programmes, both in the short and medium term. Quite a challenge, as you know, to robustly evaluate the impact of these targeted programmes. So it's great to have the opportunity also to raise questions. Each speaker will speak for about 20 minutes, and then we've got 10 minutes for Q&A. So lots of time for you to ask questions, those tricky questions about how we robustly use this data to understand the impact on children's lives. Okay, so I'm going to go straight now to our first speaker, who is Sarah Cattan. Sarah, we're delighted to welcome you. So Sarah is Research Fellow at the Institute for Fiscal Studies. She joins us to talk about evaluation of Sure Start. So IFS has been running a really interesting program of work evaluating Sure Start. Sarah's own interests are on inequality within and across generations. So Sarah, without further ado, I'm going to hand over to you. Thank you very much.
Thank you very much, Karen.
Thank you very much.
I'm going to share my screen. Can you just confirm that you see my presentation? Yeah,
we can see.
Great.
Yeah.
Fantastic. So I'll get started. Thanks very much for the invitation. I'm going to present basically just an overview, given the time that I have, of a very big program of work that we conducted at the IFS over the last 10 years. And this has involved a lot of colleagues, both at IFS and at UCL. So as you said, this work is about Sure Start in England and aims to evaluate the short and medium-term effects that the program had on children's outcomes. A little bit of background. So Sure Start was really a cornerstone of early years policy in England throughout the 2000s. We can go back to the Comprehensive Spending Review of 1998, where the program was initially announced, and where it really laid out its aims quite clearly. It said the package of Sure Start services will work with parents to promote the physical, intellectual, and social development of the children served. And basically what we set out to do 20 or more years later was to really try to understand what impacts this program really had on the children and families that it served, and whether the initial aims of the programs were indeed met through this investment. There had been other evaluations of the program, which and I won't have time to go in detail into those, but we very much see our work as complementing the work of previous evaluations, which tend to look at shorter term outcomes. We're saying as part of this seminar that to be able to do this work, we have immensely benefited from administrative data sets, some of them that existed when we started, but some of them that have become available as we were doing the work, and that have really allowed us to sort of expand the scope of the evaluation. So the Sure Start program was introduced in 1999, and through the 2000s was expanded and rolled out across all areas of England until 2010. This is when really the program peaked, and our evaluation looks at this expansion period. As you saw, Sure Start had the broad aim of improving children's development, multiple dimensions of that. And the way that he aimed to do this was via building a network of one-stop shops that offered a wide range of services for children and families of children between the age of 0 to 4. The exact service offer changed a little bit over the years, but broadly, it included opportunities for early learning and childcare, parenting support, pre- and postnatal health services, support for parents who wanted to get back into education or employment, and support for children with special education needs. By 2010, so at the peak of the program, the Sure Start program received a third of total early years funding, and about £2 billion per year, so quite a substantial investment. Now, in terms of the research questions that we set out to answer, well, broadly, we wanted to understand the effects that the program had on children's outcomes over the short and the longer term. And we essentially looked at a wide range of outcomes that were likely, or that we hypothesized could have been affected by the program, given the services that it offered. We looked at test scores from the age of 5 to the age of 16 using, at key stages. We evaluated the effects of the program on school absences and exclusions in primary and secondary school. We looked at hospitalizations from infancy to the age of 15. We also looked at support for special education needs, criminal behavior up to the age of 16, and lastly, interactions of families with children's social care services. So, as you see, a wide range of outcomes. So, given the services that Sure Start offered in these one-stop shops, offered or at least aimed to join up and provide greater access to local families. There are a number of channels through which we might hypothesize the outcomes that I've just set out might have been affected. And we can sort of range those different mechanisms or channels from more direct to less direct ones. So the first one is that obviously Sure Start offered a number of services, and that would have changed, through that, families might have greater interaction with support services, for example, help with special education needs, health services, etc. So that would be one channel through which we might see some outcomes shifting. There were also services that provided more direct stimulation and interactions and support for learning for children. And that would have been another more direct channels through which we might see improvements in children's development. There were also a few services that were very much aimed at supporting parents in their parenting and at shifting parenting behaviors and the home environment. And through that, as we know of the importance of the home environment on children's development, we might have also hypothesized some impacts on some of the outcomes that we're looking at. And lastly, because Sure Start essentially affected broad communities, it affected children's peers as well. And it might have changed by, bringing people together or different people together. It might also have had an impact on families' relationships with peers. And therefore, that could be another channel through which the program could have affected some of the outcomes that we consider. Now, let me say a little bit more about the data and methodology, and this is very relevant for this particular seminar on evaluation using administrative data. So, throughout this project, we've used a number of large-scale administrative data sets that capture all or most of the population. The first one is the National Pupil Database, the NPD, which contains test scores, information about special education needs, absence and exclusions, and that is linked to Sensei on children's context with social care services. So we've used all of that. In terms of test scores, I should say we're using the Early Years Foundation Stage Profile, as well as Key Stage 1, Key Stage 2, and Key Stage 4 scores. We also used to look at criminal behavior. We use the Police National Computer, the PNC data, linked to the NPD, so that we start with the universe of children, or at least children who are state educated, and know for all of these children whether they have records in the PNC, and when and for what type of offense. And lastly, we also use the Hospital Episode Statistics, or HES, which contains data on all hospitalizations or admissions to NHS hospitals in England. And for each admission, provides information about the diagnostic, obviously the date of the admission, the diagnostic, the cause of admission, as well as a few other characteristics about the children. We could have used, I should say here, we could have used each child, but at the time that we conducted this analysis on hospitalizations, the each child data was not yet available. Now, in terms of our method of evaluation, so we implement a difference-in-difference methodology that leverages the rollout of Sure Start centers across areas and cohorts. So essentially, between the period between 1999 and 2010, every year we see new centers popping up across different areas of England. And what that does is it varies, it creates variation in how in the families access to a Sure Start center. And over time, obviously, there is more and more access. So the difference-in-difference methodology here, what it does is essentially that it compares, so we take a small area, let's say, LSOA. And because we have data on the outcomes of cohorts living in that or growing up in that small neighborhood, we can first look at the change in outcomes between the successive cohorts within an area. And then we do that for all areas and can compare the change in trends across areas. And what that allows us to do is to essentially look at the relationship between the Sure Start rollout and children's outcomes, but stripping out permanent differences in neighborhoods, as well as national differences over time in outcomes. So sort of national trends in outcomes. So as I said, in this evaluation, we're focusing on the impact of families and children having access to centers while growing up, so between the age of 0 to 4, rather than looking at or trying to evaluate the impact of actually using those services. This is for two reasons. The first one is that there's no data on actually which services, which families and which services they use, which families use the centers and which services they actually used in these centers. But also from a policy evaluation perspective, focusing on the impact of access, so, which is essentially the impact of opening up a new center in an area and looking at identify the impact that it had on outcomes of all children in this area, is very policy relevant because this is what government has more leverage on rather than exactly who attends and which services they use. And we define, depending on the data set that we have to define our measure of access in slightly different ways. For all outcomes except hospitalizations, we define access as living close, so within 2.5 kilometers, although we've done loads of robustness checks with other distances. But here we'll go with living within 2.5 kilometers, or walking distance of a center as a child, in the early years. And then for hospitalization outcomes, our measure of access is measured as having more centers within the local authority that the child grew up in. So let me move on to the effects of Sure Start that we find. So first, looking at educational attainment. So we find that children who lived within 2.5 kilometers of a center saw significant improvements in their GCSE scores at age 16. We find a 5% of a standard deviation improvement, and this is about 1 percentage point. This is equivalent to those children being 1 percentage point more likely to get 5 good GCSEs relative to children who lived farther away and who didn't have access. These impacts on educational attainment were actually visible even earlier on. At age 5, we also see an improvement, although it's not statistically significant. But from the age of 7 and then 11, we also see significant and positive impacts of having access to Sure Start while growing up. Next, we look at special education needs. And here we split this analysis across two outcomes. First, we look at SEN support, which is the sort of lighter touch type of support, and from EHC plan, which are those plans that are for children who require greater intensity of support. Interestingly, so for EHC plans, we don't really find any impacts of Sure Start. However, for SEN support, we find that those children who had access to a center while growing up, first, were more likely to have a special education need being reported at age 5. However, the sign of that effect changes from the age of 7 onwards. And all of those impacts from the age of 7 onwards are significant. And we see that for those children who had access to Sure Start, actually we see reductions in special education needs, in their probability of having a special education need. And what that pattern might suggest is that Sure Start may have actually led to identify perhaps earlier children who needed some support, but may have actually decreased thanks to this, or thanks to other channels through which Sure Start operated. It may have led to a reduction in underlying need. And this is what we see from age 7 to 16. Next, we look at school absences, so learning time. Here, what we find is a reduction in unauthorized school absences, which is visible from the age of 6 through the age of 15. And we see that that effect actually increases as children age. And lastly, we look at health, and in particular hospitalizations. So it's more of a healthcare usage rather than a pure measure of health. But here what we find is that children who had, again, more access to a Sure Start center in the local authority that they grew up in, first in infancy, they were more likely to be admitted to hospitals. So you see there's a 10% increase in the probability of being admitted in hospitals at the age of 1. That decreases slightly and becomes insignificant at the age of 2 and onwards. But then around the age of 5, we actually see a reversal of the sign of that effect. So from the age of 5, and throughout, so primary school age and adolescence, we see that actually Sure Start would have led to a reduction in children's hospitalizations. And the magnitude of those effects is relatively large. We see, for example, at the age of 12, that there is about a 10% reduction in the probability of being hospitalized at that age. So essentially, Sure Start would have averted, first pushed more families into going to the hospital, and then later on actually averted hospitalizations. So we tried, this is for all causes of admissions to hospitals. And what we did in this part of the analysis was to look at actually individual and specific causes of admission to understand a bit more what these patterns, what was underneath like this overall pattern. And so, as I won't have time to go into everything, but just to give you a bit of a flavor of what we found, well, first we look at hospitalizations for infectious disease. As you can see from this picture, it's a very different pattern. Here, what we see is that Sure Start would have led to an increase in hospitalizations for infectious disease in infancy. And this could have been driven, for example, by the fact that Sure Start increased interactions, perhaps between children in the centers, and children passing on germs to each other, making them slightly more sick. But it could also have been the case that Sure Start provided information to parents to prompt them to use the right healthcare at the right time. And so it may have been that also parents were more likely to go to hospitals actually when needed. However, from the age of 4 and through, around that school transition period, we start seeing a reduction in hospitalizations for infectious diseases as a result of increased access to Sure Start. And here, what that may actually reflect is that, children, if essentially Sure Start led to an improvement in the immunity system of children who had greater access relative to others, by the time children all go to school around 5, 6, those effects might actually start disappearing, and we no longer really see an impact on that. Beyond the age of 6, 7. Now, we also looked at external causes. These are accidents, injuries, poisoning, etc. And here again, the pattern is completely different. And we see from most ages, actually, already from infancy, big, significant reductions in hospitalizations for these types of causes. And again, what that may suggest about how Sure Start worked is that it maybe led to a different, a safer home environment, perhaps different parenting behaviors around the house, and that could have led to also children, behaving differently and being less prone to actually injuring themselves. So all of these kind of hypotheses that I'm stating about the sort of underlying mechanisms and the link between services and the sort of effects on outcomes that we see are really more kind of suggestive. This is not something that we can strongly verify in the data, but these are kind of hypotheses that we put together from looking at a range of outcomes and looking at the patterns of effects from very, very early on to adolescence. Now, so as I've said, we see benefits across, wide range of outcomes, but it would be wrong to think that, Sure Start was a silver bullet. Indeed, we find no evidence of an effect, as I said, on EHC plans in the short or medium term. We see only a limited effect on the proportion of students with a criminal record. And we see also a limited effect of Sure Start on children's interaction with the social care system. We find evidence of relatively widespread effects across a lot of different subgroups, but in some case, we find some evidence of larger effects for FSM eligible students, so more disadvantaged students. On some outcomes, effects are more pronounced for boys than they are for girls, and also for non-white children rather than relative to white children. But it's difficult to really say that one group benefited a lot more than others. So the last thing I will just talk about briefly is how we bring this, wealth of impact estimates together to try and draw a cost-benefit analysis of the program. So many of the outcomes that we look at are associated with significant financial benefits or cost for government and for individuals. And what we do here, our approach is essentially to think about a representative cohort at the peak of Sure Start, so in 2010, looking at how much they had access to Sure Start and how much we're spending on Sure Start, and think about the ways in which their outcomes in the period that we look at or that we have data on their outcomes, but also beyond, might have been affected. And all of this is measured in today's terms. I have to, caveat this this part of the analysis a little bit because, as we know, cost-benefit analysis are inherently difficult and require making assumptions. Many of the benefits that we incorporate here are not realized; they're still in the future and, based on predictions. So we should see the analysis as providing a best estimate of the cost-benefit of Sure Start, and as aiming to give a sense of scale, but definitely not a very, very precise number. So at the peak of the program, we're spending, this is in real terms, 2.5 billion on it. And in terms of the benefits, so first, the benefits accrued for the individuals who attended the centers, and that was visible through higher educational attainment, which led to increased earnings and other benefits from other outcomes. We also account for any reductions in later spending from the government, from some of the outcomes, the reductions in hospitalizations, for example. And also from those increased earnings resulting from increased educational attainment, we also incorporate the increased tax income that the government would accrue through that channel. And in total, the benefits both to the attendees and to the government would amount to at least 5.8 billion for that cohort. So at least twice as high as the upfront cost of Sure Start. So a few key takeaways to conclude. So Sure Start benefited a wide range of outcomes for children and young people in England. Many of the impacts of Sure Start were remarkably long-lasting. But as I explained, Sure Start was not a silver bullet at improving every single outcome that we can think of. And the benefits were widespread across the population. And there is some suggestion in our heterogeneity analysis that the program may have been inequality reducing. And from the cost-benefit analysis, we conclude that the long-run benefits of the policy are likely to significantly exceed its costs. Again, want to reiterate that this research would not have been possible without, those administrative data sets and the recent linkages between data sets that have, been done over the last decade. So thank you very much.
Thank you, Sarah. That was really clear and really excellent, very engaging. We've got some questions in the chat. Lucy, do you want to select a couple of questions and just put them to Sarah?
I will do. So the first question, Sarah, was Sure Start delivered universally to more or less the same standard across all regions in England, or was its delivery dependent upon regional budgets, etc., which would obviously affect its ability to make a difference in more socioeconomically deprived areas?
Yeah, great question. So with Sure Start, we essentially had like 4 phases of rollout. The first one was Sure Start local programs, which were really only targeted at the areas in the 20% most deprived areas of England. And then from 2004 to 2006, it's the phase 1 of children centers. And again, like there's a very strong focus on those 20% most deprived areas. Then we start moving into the 30% most deprived areas from 2006 and 8. And then the last 2 years of the rollout, Sure Start really expands in all remaining areas. So basically what that means is that by the end of the rollout, we have Sure Start centers pretty much in every community, but still with a higher representation in more disadvantaged areas. Also, the funding for centers was more generous in this earlier phase of the expansion, so under local programs, and it remains so in those areas actually even later. So we have, I think I actually looked at the data yesterday. I think we were spending in like those centers called local programs, and that still remain children's centers, but that originated as local programs. I think we're spending about 1 million per year on a center. And in centers where that were in like slightly less deprived areas, we were spending about £600,000 per year. And so actually the way the funding was allocated would have tended to advantage areas with greater deprivation and greater need.
Brilliant. Thank you, Sarah. Will, there's a question from you as well, but I think Sarah's probably wrapped that up in her last response about prioritization of the areas. So a question about what do you think could be driving the findings about unauthorized school absences? That seems counterintuitive.
Well, I think so. We thought about these results alongside a number of other outcomes that could reflect a change in children's emotional and behavioral development. So as I mentioned during the talk, we find those big reductions in admissions to hospitals for external causes, which are often, very highly correlated with like children's behavior actually. And we did some we used the MCS data to actually look at that link. And I think the reduction in absences, in unauthorized absences, could also reflect an improvement in children's behavior. It could also reflect, different dynamics at home. Family, from the previous evaluations of Sure Start, which actually collected data within households on families functioning, there was those evaluations found an improvement in family functioning and parent-child relationship. So it could also have been, that being, one channel, improving children's behavior and reducing unauthorized absences, which are often essentially truancy.
Brilliant. We've had lots of questions. I'm going to ask you one last question and then see whether you can respond to the rest by typing your answer, Sarah, if that's okay.
Sure.
So a question on, very interesting talk. Have you had any engagement with policymakers and what was their response?
A lot of engagement with policymakers. I have to say that the timing of the publication was quite serendipitous, and this doesn't happen a lot, I think in research, but it took us so long to acquire all of this data. And we would have published this research, years before, had we not waited for years to get some of this data. But actually, in the end, it happened that we published a little bit before, as the new government was coming in, Secretary of State was interested in the early years, few months before the Best Start in Life strategy, which gives, which recognizes the importance of family services and joined up family services for the early years. So yes, we had loads of engagement during the research, but also around the publication of it with policymakers at DFE, DHSC, MOJ, Number 10, and beyond.
That's great. Thank you, Sarah.
Thank you, Lucy. That's lovely. And thank you to Sarah. Really interesting. And as you say, took you a long time to get hold of the data, but the findings still very relevant, I think, to current policy debates. Okay, so thank you, Sarah, and welcome, Gareth. So hi, Gareth. So Gareth is a change to our programme for today, and we thank Gareth for replacing Menglei Zhang, who was unable to make it today, but Gareth is here instead. So Gareth is a research fellow at Bristol University, has a keen interest in the use of admin data, has previously looked at the measurement of mental health, data quality issues. But Gareth is going to take us through an illustration of how we use administrative data to evaluate Sure Start in Northern Ireland. So Gareth, over to you and thank you.
Thanks, Karen. I'm just going to try the same thing that everyone always does, where you try and share your screen and hope that it works. And I apologize if it doesn't, despite having been doing this for years now. Do you see a PowerPoint slide, which hopefully is going to go to presentation mode? Does that work? Is that all right? Is somebody?
That's good. That's good.
Grand. All right.
Yeah.
Thank you so much. So yeah, hi, I'm Gareth Griffith. I'm a researcher at the University of Bristol. As alluded to by Karen, I am not the person who's intended to give this talk initially, but the lead author on the study, Menglei Zhang, has actually been called to hustle because I think there was an imminent expected arrival in his family, which is very, very exciting. But I apologize for my not having practiced this as much as he would have done, because minimal notice, as is the way with such things. But so yeah, I'm going to present to you a little bit around exploring the impact of Sure Start in Northern Ireland. So it's a similar intervention to the one that Sarah just talked to us about. But this is predominantly with colleagues. So Menglei and his colleagues work at Cascade, which is the Children's Social Care Research and Development Centre in Cardiff, the University of Cardiff, and social policy colleagues over there. And I work in the medical school in the epidemiology department here in Bristol. I say here, as though you know where I am. I'm in Bristol. So I'm going to talk you through a little bit. First of all, so the team, again, as I say, this is certainly not a solo effort by me. So this is Professor, apologies, that's Professor Sally Holland on the left. So she's a professor of social care who works in Cascade with years of experience. She's a former Children's Commissioner for Wales, in fact. That's Menglei Zhang. I don't know if you can see my mouse, but I'm wiggling it around his face. He's the PI on this project and a causal inference whiz with a lot of expertise in social policy, and particularly he and I share an interest in geographical effects and regional differences because we were both in geography departments previously. And this is Martin Elliott, who is a senior research fellow also in Cascade with particular interest in social policy around looked after children. And I'm a slightly hairier version of that one on the right. I work in, as I said, mental health measurement and selection into administrative and healthcare data. So one of this is a slightly adapted presentation that we gave to some stakeholders in Northern Ireland when we were there a few weeks ago. And one of the things which we immediately were like, we should justify this is why are we, a bunch of researchers from not Northern Ireland, coming to Northern Ireland to try and evaluate their social policies? So I should say that this is work which was funded by the ESRC as part of their Creating Opportunities, Improving Outcomes framework, which gave a large amount of money intended to tackle regional disparities across the UK. So relatively high up in UKRI, there is an acknowledgement that across the political spectrum, there's agreement that regional disparities that exist in the UK do real social and economic damage. And so this was a part of 17. So this actually funded 17 projects. We are one of those. Within the sort of total intention was to fund studies which are evaluating efforts to, or policy efforts to reduce inter-regional inequalities. So I'm going to talk to you a little bit about Sure Start Northern Ireland, which I actually need to less than I'd anticipated, because it has been talked about in the context of Sure Start in England. Sure Start Northern Ireland was deployed around a similar time in 2001. It was actually expanded in 2006 and subsequently in 2013. And now it expands, it covers around 40% of areas in Northern Ireland. But it provides a huge range of services, as some of which were outlined in the Sure Start England. So there's a lot of early years advice. There is services available from your first antenatal visit, so pregnancy, until age 3 of the child. So it's early years care, and there's quite a wide range of services that are offered as a consequence of it. Those services are both home and centre based, and they are parenting, education, and play therapies for the children. And the important thing for our study design and for our research is that it's universal within areas. So you are eligible for Sure Start if you live in an area which is eligible for Sure Start, which I'll talk about a little bit in a minute, because this informs part of our research design. So we wanted to know, and I apologize, I also never know this with Zoom, whether you can see the little block that is you guys on here. But so we wanted to know what difference Sure Start made to children and families. And in order to do so, we need data, ADR UK, administrative data. Presumably don't need to sales pitch to you that we need good data, but we also need a very solid research design. So to talk a little bit about the data that we use for this, first and foremost, so in Northern Ireland, this whole project has really been facilitated by the Honest Broker Service. So they house the sort of administrative and routinely collected data that comes through health and social care in Northern Ireland. And you can link to a whole range of services. We went at this stakeholder event we put on not so long ago. They gave a talk about the type of data they have, and it is a wealth of information. It's stuff on educational outcomes. There is stuff on policy, engagement of social services. There is stuff on healthcare around your hospitalizations, your GP records, your dental service. They are all linked through this Honest Broker Service. And it becomes an incredibly valuable resource for us because, again, presumably I don't need to sales pitch this, because it's all administrative and it's collected by routine. It's collected without excess funds required to do so. It means that for us, this whole project has turned around within about 2 years, a year and a half or so, because all of the data that we were accessing was secondary. And because, again, of this eligibility criteria for the Sure Start Northern Ireland intervention being area-based, you can evaluate your intention to treat Esteman using solely area-level data. So the linkage is via your health and social care number, I should say, across things. So you link across many different services. And we particularly want to highlight NIMATS, which is the Northern Ireland Regional Maternity System, which has a phenomenal amount of clinical and demographic data on mums and infants in Northern Ireland. So it represents, over this period from 2006 to 2020, it represents about 370,000 live births, or more than live births, and it has data from pregnancy through to delivery. So again, from that first antenatal visit to delivery with the mums. It then links to your health records up until 2024, and social services, so your interactions with the social care system, and so on until 2017. And this is the data that we used principally in this study. Now, I'm going to talk to you a little bit about the key outcomes. Again, we had, there are a phenomenal amount, and Sarah very rightly put, there is a phenomenal amount of things that Sure Start could or may have an impact on. And one of the things that we found as part of this study is we needed to refine early on what we wanted to look at. And it was largely, well, at least somewhat decided by data availability. So we wanted to look at outcomes up until age 5, which is distinct from the IFS study. So we are looking at earlier outcomes that are less long-term. We looked at the engagement with social care, so whether children were identified as in need, or sorry, whether they were preferred, identified as in need, and so on, whether they were hospitalized and hospitalization by reasons for hospitalization. We also have dental records, which I don't think we have analyzed as of yet, and GP registration information. And we also had some, there is information on the health outcomes at birth, which I'll touch on a little bit in a second, as to why we may or may not expect that there would be significant effects on health outcomes at birth. And again, all of this is enabled by administrative data, which is linked very helpfully through the Honest Broker service in Northern Ireland. So we talk a little bit about the existing evidence for the effect of Sure Start in Northern Ireland. Now, as Sarah mentioned, there are many reasons for which the places which receive Sure Start are pre-existingly different to the places which don't receive Sure Start. And I'm going to talk a little bit about the eligibility for Sure Start. We focus specifically on one expansion in this project, which I'll go on to in a minute. But we can see here, so this is the number of mothers who smoked during pregnancy. And so this is recorded at an antenatal booking appointment. So this is a thing that happens literally before Sure Start ever meets them. Like this is at the baseline, and this is the Sure Start report card. And we see that the mothers who live in Sure Start areas, the fraction of those who smoke at prior to birth at their antenatal booking appointment is around 3 times as higher as those mums who smoke, it's 3 times as higher as those who live not in Sure Start eligible areas. And that is really important, because it means that if we do a naive analysis where we just compare the areas which receive Sure Start with the areas which don't, we might incorrectly prescribe that sort of difference to the function of Sure Start. So what we need to think carefully about how we can ensure what we would call exchangeability between these 2 groups. And this is something that we would call baseline confounding. So this is confounding. It's a common cause that exists prior to the onset of the study. Now, our design, one of the things which I've alluded to a couple of times, is that actually in 2006, 2008, there was a policy target which was to expand the number of areas which were eligible for Sure Start up to the 20% most deprived wards in Northern Ireland. So there were around 100 wards at this time which were already eligible from the first introduction of Sure Start Northern Ireland, and they then wanted to expand it up until this 20% line. And you can see here that although it's an imperfect discontinuity, there is a discontinuity around this 80% threshold. Again, I apologize if you can't see my mouse, I'm just wiggling it for nothing. But so on the left-hand side of this graph, you see this is grouped by deprivation decile along the x-axis, and you see that there is a very sharp increase around this 80% deprivation threshold, where the policy intention was to make this available to everyone above this threshold. And we find that it's going to become a repeating theme, possibly in this discussion, depending on how long I have, that the policy brief doesn't actually necessarily map that closely to what happened on the ground. But that is a I guess which is to say that non-compliance in this sense, rather than in your trial list, if there are trialists in the audience, the non-compliance is basically that this was a policy mission. So it's imperfectly enforced in terms of which areas are eligible and not for this. But there are approximately 80 areas which are added in this expansion from 2006 to 2008. Now, the interesting thing from a study design perspective is that 20% is just a number. There's no reason for which 20% is useful, right? Meng Lei does this really nice analogy where he gets given on his 10th wedding anniversary, he got given a really nice present from his wife. And he was like, there was no really nice present for the 11th anniversary. There's no really nice present for the 9th anniversary. It is just because we like nice round numbers that end in a 0. There's no other reason. And actually, there's been some suggestion that if you give people numbers either side of that and they're more sort of specified, people become slightly suspicious of. They're like, why exactly did you use 19.6% and not 20? So if we were to rank all of the families or all of the mums in Northern Ireland in terms of the deprivation of the area they lived in, there would be nothing substantive separating the people from the 90.9th percentile to the 20th percentile, and similarly from the 20th percentile to the 20.1st percentile. And that means that we have this really nice, comparison where, aside from the likelihood of Sure Start being implemented, there is very, very little which separates these people either side of this discontinuity. And this gives us what we call our regression discontinuity design. I always think of this. I gave this example in a lecture the other day, but it's like when you're changing the volume on a TV remote, and then the students, some of the students in the room didn't remember changing TV remotes to nice round numbers, and it made me feel really old. But it's like when you're changing the volume on a TV, you leave it on a number ending in a 0 or 5, or unhinged. So if we look at the areas which would have been eligible for this intervention, we can see that actually, so on the right-hand side of this graph, these are the areas in the top 20%, and we see that this is so equal. Well, I'm trying to say that there are equal numbers of, unequal numbers of areas on either side of this, and actually, if we were to compare all the way across this axis on the bottom, we would certainly find that there were confounders which are mismatched. So what we want to do really is we want to hone in on this point where there is this discontinuity, and we really want to take just these areas, so we can compare areas which are just either side of being eligible for the intervention of Sure Start. And this means that so for all subsequent graphics that we're going to use in this, you will see that we are just presenting these 6 bars from this bar chart. And the assumption here is that these areas are very, very similar, apart from whether they receive treatment or not. This is a very small window of deprivation. And so these 6 bars contain about 38,000 births over our study window, which is around 7,000 per year. It's 186 wards, and it's over this 7-year window between 2006 and 2013. And we've excluded from this the people who were, or the areas, sorry, which were eligible for which were in the first Sure Start expansion. So to give some example of what we might expect, this is the study. So I'm just going to quickly reference the fact that we had to pre-register a lot of this stuff, because similar to Sarah's latter point about engagement with policymakers, we have experience in engaging with policymakers around this kind of stuff. And actually, it's quite often the case that when you publish your results, you make your results known, people look at them and say, oh, why didn't you go and look at this? Why didn't you go and look at that? So what we wanted to do is we wanted to have a pre-registration saying that before we looked at any of the data, we had all of the likely outcomes based on the policy document, which again is not necessarily the most accurate reflection of what happened on the ground. But based on the policy document, we pre-registered the outcomes of interest for ourselves so that we could have, I guess, essentially to insulate against us hypothesizing after we'd seen some of the results. But so this is one of the variables which we had in as a sort of sense check, sensitivity analysis, which is to say that we don't expect the percentage of mothers smoking at the start of pregnancy to have any difference either side of this threshold. Right? We would expect the result to stay the same, because this is something that happens before the intervention from Sure Start. This would imply that we had baseline confounding. And actually, we see that this is largely this is adhered to. We see that the line is straight. Right? We don't see that there is a difference in the areas which were ineligible for Sure Start and the areas which had a much higher likelihood of receiving Sure Start. So I'm going to talk to you a little bit now about the social care outcomes, which we looked at for our study. Again, this is the focus of it, because the colleagues in Cardiff are principally social policy researchers. So again, to remind you, this is around 38,000 children in this eligibility window over this period. So it's around 7,500 children per year. So we wanted to look at the percentage of children who are referred to social services within the first 5 years of their life. So this is anticipating anybody in Northern Ireland, anybody can refer a child, I should say, to social services. So it doesn't necessarily, you can self-refer, but it can also be a referral on behalf of someone else. So you could refer, if you'd seen a child who was, you considered at risk, you could ask for them to be evaluated by social services. And what I would draw your eye to here is that on the left-hand side of this, we have this very strong upwards trend that as deprivation increases, there is in general a higher fraction of children referred to social services. And what we actually find is that in the areas which are eligible for Sure Start, we find that actually the absolute reduction is around 5.9% lower likelihood of being referred, which if you multiply it out by the prevalence of children across, the number of children who receive Sure Start totally, that's a reduction of around 440 children per year who are being referred to social services. Now, obviously, the implication with that is that this is just referrals. We wanted to know whether that reflects anything further progression through the care system. So we wanted to look at what fraction of those referrals are identified as a child in need. Again, you see on the left that the association with deprivation on the bottom is that as deprivation increases, you see higher numbers of referrals being identified as children in need. And actually, we see that in the areas which are eligible for Sure Start, there is a 4.1% lower likelihood of children becoming a child in need, which again, so both of these are absolute absolute percentages, the actual proportional reduction is around 30% for each of them. So you've got a pretty significant reduction in the number of children who are both referred and becoming a child in need. And this reduction is around 300 children per year. Again, if this generalizes to all Sure Start Northern Ireland areas. So we're going to talk a little bit now about the health outcomes. Now, as I suggested before, when we went to go and do some engagement with stakeholders and with practitioners on the ground, I think there was a lot of skepticism about whether you would find things which were, or there was more skepticism, I should say, about whether it would be plausible that you would find meaningful differences around outcomes at birth, because you only have the window from that first antenatal visit to birth to make a difference to an outcome. And I'm going to show you here that we actually found no difference. There is no difference in this between the areas which received Sure Start and the areas which didn't for the average birth weight of the child. Similarly, so these are similar to the outcomes that were compared in the IFS study. We don't find a detectable effect on the absolute number of inpatient episodes for a child before the age of 5. But I should say now that we've gone and done a little bit more digging around that first one, and that there is some evidence. It appears that something's going on with inpatient episodes. So that is where you are recorded as having occupied a bed for a treatment at some point in the hospital. There is some evidence for a reduction for childhood injury. So for inpatient episodes for childhood injury, and for inpatient episodes for gastroenteritis, which is to say upset tummies, which is something I wouldn't have necessarily anticipated. But that was something that stimulated real conversation when we were in Belfast, because there is a known link between gastroenteritis and breastfeeding. We don't see there's no significant change in the percentage of people registered with their GP, but you can see that the prevalence of registration is already very, very high. We wanted to then look at the sequelae of that transition through the social care system. So looked after children, is there a difference in the number of children who are identified as at risk, then going on to become a child or needing to be on the child protection register? You're going to have to take my word for it. Again, this is a stakeholder presentation, so we were told in advance that we shouldn't put error bars on it because it would confuse people. But there is no difference in the blue and the red on that. If you take the regression discontinuity estimate, there is the error bars would all overlap. And similarly, in the likelihood of becoming a looked after child, which is the next progression on, so about 1% of children go on to become looked after children. So the final thing that we wanted to do, having looked at this, was unpicking that reduction in referrals. So are there subgroup effects to see who seems to be receiving, or are there groups who are receiving the greatest benefit from Sure Start in terms of their likelihood of having their children or infants referred to social care? And so what we wanted to do is we wanted to unpick this a little bit. So we had a couple of hypotheses for who might be experiencing a slightly larger reduction in referrals. So again, these axes on the Y are negative, so that they're reductions. Lower is good, essentially. So this is the difference between the sex of the child, so whether infant sex seems to show any difference in the number of referred children. And we found that actually for that there is, again, apologies for lack of error bars in this, there is no indication that the reduction in referrals is substantially larger for the male infants. There's no difference between those, that the error bars overlap. But when we look at the difference between mums who are young mums and mums who are 22 and older, we find actually that there's a huge difference in the reduction in referrals for the younger mothers, so the children of the younger mothers, that the effect, the reduction for them is around 15%. So it seems to be that whilst there is a reduction for everyone in their percentage of referrals, there is strong evidence that reduction in referrals is greatest for the younger mothers. We also wanted to look at how long does this effect last. So the effect on the number of referrals by age. So again, this is within a given cohort of children, would you anticipate that they will be referred to child services in the next year? And we find that effect is strongest, so that the greatest reduction is evidenced in the first year of the child's life and sort of declines with year until around the child being around 4, which is almost exactly timed with when the intervention itself ceases. You find that there's then no difference in the likelihood of referral beyond that. So contrasting with the findings we just saw, we find that there are very positive findings initially, but that these effects seem shorter term than the IFS study in England. We also find that the results seem more positive than the original Sure Start evaluations in Northern, because of this baseline confounding issue, where if you just do like for like comparisons, it seems that the areas which receive Sure Start are more seem to have worse outcomes. And we actually, there was an independent government review of children's social services in Northern Ireland, which had, which specifically flagged the social care component of Sure Start in Northern Ireland as a key benefit. I have one slide, which is, so this is around the PPI stuff, which was conducted by Sally Holland. This was some work where they went to try and explore the reasons for which stakeholders, so this is either people who were service users or service practitioners, why they felt where the effect of Sure Start would be, or why does it work. And it was very clear from all of that stuff that the key benefits are around the community building, the contact point, and the locally, like local being the largest word, the community being local that you are meeting, so you're meeting a support network. It's actually funny. So this word staff in here is actually, that had to be anonymized because there was one specific person in one of the Sure Start centres who was so well thought of that their name kept coming up across all of them. With apologies that I've gone slightly over. Thank you. I apologize in advance if my answer to your question is you'll have to go and ask Menglei Zhang, and also that the subsequent bit of that is that he will be off on paternity leave for a little while. But yeah, so thank you to the Honest Broker Service and the ESRC for funding this work, and colleagues at Cascade, and you folks at ADR for having me come and speak. So,
thank you, Gareth. That was a really, really informative and excellent talk, and interesting to see you really probing those social care interactions, you know, in a sort of deeper way, slightly different way from Sarah. Both fascinating talks. Lucy, have we got any questions for Gareth? I know Gareth's single, but Menglei isn't here, but should we have a go with a couple of questions?
One, you have to stretch your mind back to your wording, but someone put, Gareth, do you mean the link between not being breastfed?
Yes,
and
that's exactly right. Sorry, yeah, that there is an association between breastfeeding and gastroenteritis, but that it is that direction. You're absolutely right.
Okay. Really interesting difference with maternal age. Was this case independent of household locality?
That's a really interesting question. So I suspect that we'd run into power issues if we were to try and assess that based on local, as in to look at whether the specific location was an effect modifier of whether that difference for younger mums is greater. I don't know. That's a really good question that we can go and ask, because I guess there's no guarantee that geographically the younger mums are consistently spread. That was the thing that we looked at initially in our analyses, but I haven't personally looked at that again since. So I can ask Menglei, with apologies that that's going to be my answer for a couple of these things. That he's the one who spends the most time on this project. But I think that yeah, it's a really interesting question to see whether. So I think that came out from the stakeholder events also. Is that a lot of the benefit of Sure Start seems to be around this kind of social stuff and destigmatizing to some extent the accessing of social care, because it is universal within an area. So I feel like maybe there's something to do with the younger mums coming in and being part of that cohort that feels like it is that it is part of the benefit. I'm trying to sort of second guess what the subsequent mechanism for this hypothesized thing might be, but I can't see the question now. But if you have an idea for a proposed mechanism for why that might differ by places, that'd be fantastic to hear.
Brilliant. There was a thank you for the presentation comment, and then someone asked also about whether you have had opportunity to use qualitative data.
Yeah, that's a great question. So the formal investigation doesn't have qualitative data within it, but it has a huge amount of stakeholder engagement and people with it. So like PPI involvement throughout it, which is run by Professor Sally Holland, who I mentioned on the talk. She is a PPI expert, and as I said, was the Children's Commissioner for Wales at one point, and as part of the weird, I say weird, I don't mean weird, there's like a Children's Commissioners group that she also knows the Children's Commissioner at the time from Northern Ireland. So the two of them went and conducted some of this stakeholder engagement in specific Sure Starts, and that's where a lot of these sort of findings and contextualizing of findings come from. So when we were at this event, a lot of the discussion was around, do these results make sense to you? What was surprising, what was not surprising? And I think one of the things that was really striking and is a strong advocacy in my mind for going and speaking to your stakeholders in these events was that actually the benefits or the proposed benefits differed like slightly but meaningfully between the different Sure Start centres, and those of you who study effect heterogeneity and stuff, you would anticipate that those are all being smushed together in your single estimate of what this is. So without having, as I said, we pre-registered it so that we didn't have issues of why didn't you go and look at this, why didn't you go and look at this. But without having a priori hypotheses of which subgroups you would anticipate to find stronger effects in, I think that's probably where qualitative data would be really, really, or like a mixed method study for this would be really, really beneficial. Is going in and interviewing people, and then you could have an a priori expectation for which subgroups you would expect to find stronger effects in, or more, because there's definitely anecdotally so much experience there and a wealth of information around. Oh, sorry. So we did, yeah. So do you want me to answer that one?
Yeah.
Yes, go for it.
So yeah, so we did. It's a regression discontinuity design. So the bar charts were there because this is a presentation to stakeholders that we gave in Belfast, and we were told that bar charts were more interpretable than like lines with error bars around them. But so if I flick back, or I can put it in the chat, the pre-registration, and we have a working paper that is about to be done, although it's probably about to be delayed by the fact that Pinglei's having a baby. We have a working paper which will be hopefully put online in the next month or so. And we can look at, in that, there'll be further details of the analysis method.
Brilliant. Thank you, Gareth.
Thank you. Thank you, Gareth. That was so helpful and so informative. Really, really engaging talk. It's a great afternoon so far. Anyway, last but not least, Tony. Welcome, Tony.
Thank you. Hello.
We're delighted to welcome Tony Whiffen, who is currently on secondment from Welsh Government to Cardiff University, predominantly working currently with Career Wales data, but previously involved with evaluation of Flying Start in Wales. For those of you who don't know as much about Flying Start's also an early years intervention delivered by Wales and aiming to improve life chances for young children in some of the most disadvantaged areas. So similar but different composition. And currently, I think being rolled out to about 38,000 children, Tony, but I'm sure you'll tell us a bit more about that. But anyway, over to you, Tony, and welcome. You're on mute, I think, Tony.
Thank you. Yes, hopefully my screen, you should better see my screen now.
We can see it very
Lovely.
Clear, yeah.
So this work basically relates to some work we did back in 2019 relating to Flying Start. And that starts to feel quite a while ago now, but hopefully you'll see from this presentation that we've been able to look at the impacts that the work we did has had since then. So I don't want to dwell too much on the Flying Start itself, other than to highlight the differences between Flying Start in Wales as it is compared to England and Northern Ireland, and then cover the project aims, the methodology and findings, and highlight and prioritise looking at the outcomes that have come from Flying Start and then the work we've done. So Flying Start has been running in Wales since 2006-07, mainly targeted children aged under 4 in the most disadvantaged areas of Wales. Primarily, that means those who are in the WIMD Welsh Index of Multiple Deprivation quintiles 1, so the most deprived quintile of Wales, most deprived 20%. And the aim is to improve life chances for children in those areas. And similar to England, although somewhat slightly different, is the fact that although it's targeted at young children, there's no employment support element as there is in England, but it primarily is centres around childcare for all 2-year-olds in the Flying Start area, and enhanced health visiting service, access to parenting support, parenting courses, that sort of thing. And then one of the elements of it is actually an SEN element, that there's additional support for speech, language, communication difficulties. So thinking about outcomes and stuff, we will think about going on to looking at SEN outcomes eventually, but it's as part of the intervention is SEN support. We haven't wasn't able to sort of separate that out, but that's part of the offer basically. So as I say, no employment support, but all the other elements are broadly similar to what you see in England. Let's move on. So the thinking behind Flying Start is to look at the family factors affecting the family and the characteristics of the family, parent-child interactions, and look at how as government we can support those and improve outcomes in terms of child development. It's a cross-cutting initiative which cuts across both health and education policy areas, and in slightly more detail, the outcomes are expected that children's home life is improved and more stimulating, that sort of thing. Child development cognitive development improves, home life is improved, and then general health as a result is improved. So as part of what we did for the research, we look at the different elements that we could look at in terms of what we had data for in Wales. So to say that within Wales we've got the SAIL data bank, and that holds admin data for all areas of Wales, virtually everybody in Wales, everyone resident in Wales, children resident in Wales, and it covers both health and education data sets. It's all warehoused in a one-stop one environment, so it is fairly straightforward to link data from one element to another element, and to look at cross-cutting impacts. So using the data available, we were able to sort of look across the different impacts that Flying Start has. The previous evaluations before 2019 were based on area-based analysis of Flying Start outcomes for eligible children, and the aim was to as I say, look at the cross-cutting impact of Flying Start across health, education outcomes and social care outcomes. I think we did think about looked after children, but I'm not sure we got as far as actually linking the data up for that. I don't think it's quite become available in time for this analysis. And then we were thinking about looking at a sort of what you call dosage elements. So how much Flying Start do children receive, and what is the impact of that dosage? Is there differential impacts of the level of dosage or exposure that children have to Flying Start services, and does that make a difference? And then we were carrying out this work conscious there was like to be a policy review of Flying Start in the late end of 2019. So we were conscious that we had a load of data and we needed to do something with it fairly quickly. So this was the aim was to sort of max out what we could with what we had available in order to feed into that policy review. I should say from the start that the aim was to get Flying Start data for children across more than one local authority area in Wales, and there was a sort of allied project which looked to use a method to get data from local authorities into SAIL for policy initiatives like Flying Start, and so it was developed in tandem with that project, and that project founded somewhat so that we could only have data for one or local authority. We're hoping to get more than one, but we only had data for one authority in Wales at that point in time. So we had data for Swansea that we could use. So we thought we'd do what we could with that to try and help feed into this policy review. And the data we had went back to 2005-06. So I think possibly we had some pre-Flying Start childcare data for Swansea, or it may have been the case that Swansea was a pilot area for Flying Start. I'm not sure. But the data range we had available was from 2005-06 to 2017-18, and it covered both health visitor and childcare data elements of the Flying Start offer. So two separate data sets which we could link back together and then link with other data sets. And so we, without not as elaborate as what Gareth presented, but we could simply just use the non-Flying Start children in Swansea, the comparator group, and also we used Wales as a whole for different indicators to compare with. So we could at least scratch the surface on the impact that Flying Start was having in Swansea, at least, even if we couldn't look at it on a whole Wales basis. And then both data sets were linked to hospitalisations and A&E data, school attendance data, and foundation phase on entry assessment data. So we could start to look at school readiness and that sort of thing, and the difference that Flying Start made to that. So So essentially, this is what we did. We took the Flying Start data and we linked it to birth records, and then to A&E records and hospital admission records, then to education data. Using what we know as the ALF, we can use the ALF to link across. So the ALF replaces the personal identifier data that you get on data, so name, address, postcode, date of birth, and we can produce a unique identifier or pseudo-anonymized data, which we can use to link across these data sets, and all the data sets go through the same process. So you can be fairly sure that the individual you've picked up in your data set is the same individual going through and using different services. So we linked with health and education data, and we started with low birth weight and birth data, and we looked at low birth weight, and low birth weight is known to be an indicator of deprivation. And we can see here that although low birth weight was generally decreasing in Wales, in the Flying Start areas it had a bigger impact. So the programme started in 2006-07, and then by about 2011-12, you can see that low birth rate really come down quite noticeably in the Swansea Flying Start area, such that it went actually below the Swansea level in 2014-15. And then with births to teenage mothers, you can see that there was a downward trend generally across Wales, but for Flying Start areas it was more pronounced. So that you can see that the Flying Start programme was having an impact in terms of support for young mothers, and generally, making a difference. And then we looked at A&E and presentations and hospital admissions, and we can see that as a result of that, although there was no significant impact on A&E attendances, there was a difference in terms of hospital admissions. And the previous presenters highlighted things around reasons for presentation and stuff like that. We did start to look at that because we were thinking about injuries and poisonings in the home, and how the presence of the increased presence of health visitors would help with that. And so we started to look at that, but we didn't manage to develop that analysis. But there was no significant impact found at all A&E attendance, but I think possibly we looked at that, we may have come up with something. But we can see here for hospital admissions, there was a noticeable drop for Flying Start areas for hospital admissions. The increase, I think, from 2015 and 16 onwards, I think possibly you're seeing the effect of anti-vaxxers and the effect of that on measles. I can't quantify it for sure, but you can see that although there has been an increase, the gap has closed between Flying Start areas and non-Flying Start areas. So I've made some notes and completely gone off piece with this, but anyway, let's just check if there's any other points I need to make on this. The point there is about further analyses that we're starting to look at injuries and poisons, but we didn't manage to develop that analysis because I can't remember there's a resources or whatever. So the protective effect. So I think Sarah highlighted a limited effect on hospital admissions because of Flying Start. I think that what we see is a possible protective effect of Flying Start on hospital admissions. I think it's an indirect effect. I think possible that infections were being picked up sooner because children being referred to GPs sooner, and so that you do get this sort of slight possible protective effect on hospital admissions because of Flying Start. And then, as I say, we moved on to look at not just health but education outcomes. Given the data we had, we didn't have a long run of data. We couldn't look at children beyond key stage 1, but we were able to look at absence up until to the end of key stage 1, and we can see that the overall absence level in flying start areas reduced, so it came into line with non-flying start areas. For unauthorised absence, we need to note that again the gap is closed, but from 2013-14 there was the change to regime in terms of dealing with unauthorised absences. So that's where the point where which the policy changed, so that people could get fined for taking their children on holiday and that sort of thing in term time. So again, although there was a slight increase, again the gap was closed between flying start and flying start areas. So as I say though, one of the elements we thought about in terms of flying start is not just how much, whether they get flying start, but how much flying start and children get. And we looked at different typologies of what we could do and how we could do it. And one of the key elements of the flying start offer was, of course, the childcare offer. And then, you know, so the childcare offer is a separate thing in Wales. But anyway, the childcare element of flying start. And so we looked at how much flying start childcare received and how much that would make a difference to the children, basically. And so we developed a categorization of childcare based upon not just the number of sessions that children agreed would attend, but also percentage of sessions that they actually attended. So we actually had data on the number of sessions they had signed up for, but also the number of sessions they actually attended. So we was able to use that and develop that into a typology to look at, to measure the dosage for flying start. And we came up with something which is based upon effectively 4 days a week over I think it's 2 or 3 terms. So 156 is the magic number. So that is the equivalent of 4 days a week. And then anything below that is less than 4 days a week. And then we looked at based upon as we sort of started to cut the data, there seemed to be a sort of distinct break between those attending 80% of more than 80% of the time they agreed to sign up for, and then those who attend less than 80%. And you can see there that the data breaks down fairly neatly into sort of some similar size groups that we could compare. So having looked at health and education outcomes for flying start as a whole, we started to break it down. Also, as you break down your data, the size of the group you get is smaller and smaller, and then so it limits generalization. But I think the key element is that you're effectively digging into the data and trying to find those nuggets of information that you want. So anyone who's familiar with using Minecraft will know that if you start to go digging in a mountain in Minecraft, you like to find lots of rocks, but what you're really hoping for is to be able to dig down and find emeralds and diamonds and all those things that can improve your Minecraft life. So the aim was, you know, that as you dug down deep into data, you're hoping to find those insights that you won't find otherwise by looking at a generalized level. So there's the aim, was to sort of dig deeper and to maximize what we can find out from the data. As I say, the generalizability was compromised as a result, but hopefully you could find something that was, something you wouldn't find otherwise by digging into the data as you had it available. So we broke down what we did for the A&E attendances into the different subgroups. So those who receive less than more levels of childcare, and there was mixed results. Possibly this is due to early exposure to infectious diseases. So if they were attending childcare, then it's possible they would they'd be more likely to pick up things like chickenpox and coughs and colds at an earlier stage than they would have been otherwise. So it's a bit of a mixed picture in terms of A&E attendances. And then again, with with hostel admissions, I think that again it's a similar sort of picture. So there's no clear pattern in terms of having more or less childcare, but it's generally lower for those with more than 80% attendance. So okay, again a limited effect. But I think where the impact was really felt from the childcare levels of childcare was in terms of school absence, and you can see here that both overall and unauthorised absence were higher, where childcare was more than 80%, had more than 80% attendance. We weren't able to verify whether this is statistically significant, but I think it's an interesting finding that in terms of school readiness, it did certainly help if children were in childcare more than 4 days a week. That's to be expected in some ways, but I think this sort of verifies the impact that the childcare element of the Flying Start could have, basically. And then the other element so that was the bulk of the work we did in 2019. And then in 2020 to 2021, we looked into the on entry assessment data. So we looked at the baseline assessments that children used to receive in Wales when they started to attend nursery units, and basically we looked at the levels for on entry assessments. It's something that's not collected anymore, but we were able to look at it, and so we did some descriptive work looking at compare levels of entry assessments for those who were in Flying Start and those who were not in Flying Start, and we could see that in actual fact that in terms of mathematical development, the children in Flying Start areas actually were better prepared for school than those who were not in Flying Start. So this was almost like an add-on, basically. But as we know, in 2020, that something else happened which affected policy interventions. So it meant that it was a bit of an afterthought, really, in terms of the impact. So this was some work, by which point I'd moved on to other things in terms of working on COVID-19 and things. So I'm less familiar with the outcomes here, but as you can see there, I think higher attendance led to higher achievement of expected levels in terms of on-entry assessments for those who had higher levels of childcare. And then again, in terms of outcomes for on-entry assessments, I think you can see that those who had more than 80% attendance had a bigger, were more likely to achieve their levels in terms of on-entry assessments. But say that the pandemic meant that it's possible that. But based on the evidence we had produced, we actually fed into the policy review, and obviously the pandemic possibly gave them a longer time to prepare in terms of the response, in terms of what would happen after the pandemic. And sorry, I lost my way again. So it's possibly gave the policy departments time to review what would happen next in terms of Flying Start, and in the early part of 2022, we saw the announcement that Flying Start would be expanded, and that the childcare element would be sort of like a priority in terms of rollout of more Flying Start in Wales. So the evidence we produced fed into that policy review, along with a lot of other evidence. And then I think the childcare element was a key part in highlighting the benefit of that, and such that now in Merthyr, that all children in Merthyr who are aged 2 will now receive the childcare element of Flying Start. So in terms of impact, you know, I think the clear evidence was a clear element in that, and in informing the further development of Flying Start in Wales, and expansion in Wales. And that's everything from me. Thank you for listening.
Thank you, Tony. That was really, really interesting. Really interesting to see you trying to capture dose. Really interesting to see you focusing on the impact of childcare, and fascinating to draw comparisons between the 3 projects. We've got, Lucy, I think, a couple of comments in the questions. A question for Tony?
Yeah, we have. Thanks, Tony. The question is, can you reflect on the potential for confounding to influence the uptake attendance comparisons? I can imagine that there are structural barriers influencing both uptake and attendance, e.g. geographic access.
Yeah, I think yeah, obviously there are limits to how much, you know, capital resources to rolling out across the whole of Wales. So it's possible that, yeah, that you would get localized effects of that. Yeah, we obviously were not able to measure for the whole of Wales, and yeah, I'm not entirely sure, actually.
That's
Perhaps
okay.
food for thought to take away, Tony.
Yes,
that's fine. Yeah.
Yeah.
Okay, so I don't think we've got any more questions in the chat for now, and we are at 1 minute past 4, so I think we'll probably move to wrap up the session. Really interesting 3 sets of presentations, just some reflections from us for Sarah and Gareth comparing the 2 Sure Start. I think it was really interesting to look at how you were trying, Gareth, to sort of really probe the impact on the social care population, social care interactions, because it felt, Sarah, from your presentation that there was generally positive impact on children in disadvantaged areas, but perhaps not meeting the children with the most complex needs. I think that the presentation then really nicely complemented by yourself, Gareth, where you were actually unraveling those referral rates in and seeing a not insignificant amount reduction in referrals into children's services. But in terms of policy relevance, I guess that's one of the key questions is, you know, we don't want to dismiss a general positive effect on disadvantaged populations, even in the absence of perhaps not providing the level of intensity and outreach work needed to deal with families with really complex needs. Because, Sarah, what you're clearly showing is a kind of positive overall impact, and saving to the public purse, etc. Is that a fair comment, looking across your 2 presentations, Sarah and Gareth? Yeah, okay. And Tony, I thought it was really interesting you kind of homing in on the dose of the childcare dose there. Someone's unanswered questions, but I think showing us a different set of questions that we might try to probe when we're evaluating the impact of these early intervention, you know, area level early intervention services, and how you look at using individual level data to look at some of that. Lucy, I don't know if you'd want to make a final comment before we just do a few more housekeeping things and draw it to a close.
No, nothing more from me. Thank you. Yeah.
Okay. I found the 3 presentations really, really interesting. I thought the whole session was extremely informative. So just to round off, so obviously this presentation will go into our resource bank as a recording. What I didn't show you in my slightly rushed intro was the 2 QR codes, Lucy, which we've got on some slides, which for audiences today, you might just want to capture these, because there's 2 catalysts that run in parallel, as I indicated at the start of the session. So ours is the community catalyst Children at Risk of Poor Outcomes, and we have our own microsite embedded within the ADR UK network general website. If you just Google it, you can find it. We can find it through this QR code. And you will find learning resources and a series of recordings of presentations there. But also just to flag the parallel community catalyst, which is youth transitions, because they also are doing a series on evaluation with some very interesting methodological events forthcoming. We're both catalysts are in the process of finalising and formulating their event programme, but I really strongly encourage you to look at both catalysts going forward and their kind of complementary agendas. Okay, so finally, we've got, as usual, our evaluation QR code. Kind of can't end an event now without this kind of rather yeah, there it is anyway. Okay, so just to say thank you all for joining us today. We've been absolutely delighted with all of our speakers. I think you've really, one of our key issues in the research agenda we produced right at the start of this catalyst, we did a consultation with stakeholders, and what stakeholders were really interested in was how we capture, measure and evaluate early intervention services. So it's great to see such high quality, interesting and innovative work going on in this space. So if there's no more comments from the rest of the team, I will leave you with the QR code and we'll see you at our next event. You know where to find our next event through the microsites that are on the ADR UK more general website space. Okay, folks.
Thank you.
Thank you very much. Good to see
Thanks
you
so much,
all.
everyone.
See you next time. Okay, bye. Bye.